ইনফেকশনস অফ দ্য রেসপিরেটরি সিস্টেম, ঠিক আছে? আপার রেসপিরেটরি ট্র্যাক্ট বলো কোথা থেকে কোথায় পর্যন্ত থাকে? নোজের পরে ল্যারিংস, বাকিগুলো কোথায় যাবে? এই পরের জন বলো, মাথায় হাত দিয়ে কি বার করলে তুমি শুনি? নোজ, ফ্যারিংস, আর তার মধ্যে কিছু নেই? নেজোফ্যারিংস, ওকে। তারপর ল্যারিংস, আর ফ্যারিংস আর ল্যারিংস এর মধ্যে জিনিসটা কোথায় যাবে? এই পাশের জন বলো, নোজ, নেজোফ্যারিংস, তারপরে এপিগ্লটিস, ল্যারিংস, হ্যাঁ, তারপরে এই পরের জন লোয়ার রেসপিরেটরি ট্র্যাক্ট। লোয়ার রেসপিরেটরি ট্র্যাক্টের আমাকে ভাগগুলো বলো, the division and the components, anatomical structure of the lower respiratory tract. Bronchiole, প্রথমেই ব্রঙ্কিওল, তাহলে ল্যারিংস এর পরে কি? ট্র্যাকিয়া, তারপর কি নামছে? ট্রি নামছে একটা গাছের মতো, ওটা কি কি বলছো? ব্রঙ্কাস, হ্যাঁ। কটা ব্রঙ্কাস আছে? হাউ মেনি? দুটো। কি কি? দুটো প্রাইমারি, লেফট অ্যান্ড রাইট। হোয়াট ইজ দ্য ফাংশন অফ আপার রেসপিরেটরি ট্র্যাক্ট? সিট ডাউন। What is the function of upper respiratory tract? Quickly. Upper respiratory tract থেকে কি লাভ হয়েছে আমার? নাক দিয়ে কি হবে? Hey, who is discussing so many things? দেখি তো। Hey, what is the function of upper respiratory tract? বসে পড়ো। Function of upper respiratory tract. Breathing. You can breathe through trachea also. Tracheostomy করে দিলে পেশেন্টটা নিঃশ্বাস নিতে পারবে তো? Tracheostomy কোথায় করে? You cut across trachea. যদি আপার রেসপিরেটরি ট্র্যাক্টে কোনো গন্ডগোল হচ্ছে কিংবা পেশেন্ট প্রলংড ভেন্টিলেটরি সাপোর্ট লাগছে, কাট অ্যাক্রস ট্র্যাকে। যাক, ব্রিদিং ইজ ওয়ান অফ দ্য ফাংশন অফ দ্য হোল রেসপিরেটরি সিস্টেম। ইউ ক্যানট কল ব্রিদিং স্পেসিফিক ফাংশন অফ দ্য আপার রেসপিরেটরি ট্র্যাক্ট। কন্ডাকশন অফ এয়ার, নো। কন্ডাকশন অফ এয়ার, ফাংশন অফ আপার রেসপিরেটরি ট্র্যাক্ট। সি, হিউমিডিফিকেশন অফ এয়ার। The upper respiratory tract functions ki air take humidify korche, and also it traps many allergens, many dust particles, allergens. It gets trapped in the upper respiratory tract. Otherwise jodi tomar shudhu trachea ekhane ekta futo thakto, sob giye lungs er moddhe joro hoto, tai na ki? Simple. Boshe paro, tumi bolo, what is the function of lower respiratory tract? Kono conduction noy, exchange of the gases. So you see, we have divided the respiratory system into upper and lower respiratory tract. Upper respiratory tract bole diyecho, it constitutes the nose, it constitutes the sinuses, jeta kew boleni, sinus is very important. It constitutes the epiglottis, pharynx, larynx and vocal cord. Vocal cord is also very important, otherwise kothatai bolte parbe na. Next hocche je lower respiratory tract. Lower respiratory tract you have right and left lungs. তার আগে you have bronchi, left primary and right primary bronchus and bronchioles. Now the thing is, the whole respiratory system, mostly the upper respiratory tract, is colonized with some organisms. Key organism? You have coagulase negative staphylococcus as a colonizer. That means it won't harm you, but it will be there. You have some diphtheroids, non-diphtheroidal Corynebacterium. Those are the things that harbor the upper respiratory system. You see, diphtheroids, Neisseria, some non-pathogenic Neisseria. You have alpha hemolytic streptococcus also as a colonizer. Kichu khetre Moraxella is also a colonizer. Kichu khetre, if you see, ventilated patients er Acinetobacter যেমন infection করতে পারে, Acinetobacter can cause a ventilator-associated pneumonia. But similarly, Acinetobacter is also a colonizer of the lower respiratory tract or the epithelium where the endotracheal tube is being placed. So that is a very important thing, that you need to differentiate between Acinetobacter which is colonizing, and you need to differentiate between Acinetobacter which is actually causing a VAP. Jetar karone we have something called as VAP criteria. This criteria was made by NHSN. So we have multiple criteria. We have radiological finding, we have colony count of the endotracheal suction, then we have any kind of altered secretion is present or not, any kind of ventilatory requirement has altered or not, suppose FiO2 is increased or PEEP is changed. So all these are the criteria to take VAP. Otherwise patient jodi Acinetobacter 4 colony thake plate, I cannot take it as a VAP. So that's why I'm telling you the Acinetobacter can be an organism for VAP, and Acinetobacter can also be a colonizer for respiratory epithelium. So mechanism of respiratory defense, as I told, the upper respiratory tract has got some epithelial mechanism, has got some epithelial antibodies. So these are the things that gets you the first line of defense while you are having any kind of infection. And you also have this mucociliary response functioned by those mucociliary cells, goblet cells, etc. So you have nasal mucus. That is a very important thing for, preventing infection. Okay. Next is, what are the diseases you have in the upper respiratory tract? So these are the diseases that we will study. Kiki acher moddhe, you have pharyngitis. When you have any inflammation of the pharynx, it's called pharyngitis. You have tonsillitis, tonsil phule geche, hameshai hocche shobar. You have laryngitis. Okay. And you have acute croup bole otage, tracheolaryngitis, tracheobronchitis. It is called croup. It mostly bachchader hoy. And one medical emergency is there in upper respiratory infection, which is called epiglottitis. Epiglottitis, if you see here, it is caused mostly by the Haemophilus influenzae type B. So why it is epiglottitis, we will see. Are kichu local infection hoy of the oral cavity. You have dental infection, you have gum infections, okay, you have periodontitis. So all these things are there in the oral cavity. The oral cavity also is a part of the upper respiratory tract. And then you have certain infections of the sinuses and nose. So tar moddhe rhinoscleroma is important, rhinitis is important, and sinusitis. Sinusitis more or less sobari thake olpo bistor, but amra matha dhorlei boli je sinusitis hoyeche, actually jinishta ta noy. Okay, we will see how it works. Lower respiratory moddhe ekটু beshi because it is a larger area. So we have bronchitis, it is mostly by viruses. We have bronchiolitis, again it is by virus, by respiratory syncytial virus. It is mostly, we can see bronchiolitis in children in pediatric age group. And then you have pertussis, that is whooping cough, Bordetella pertussis. Okay, then you have major pneumonia. Pneumonia means the involvement of the lungs. Now, when lungs are involved, it can be lobar or it can be interstitial. Lobar and interstitial, ei duto primary types of pneumonia. Then you have pulmonary tuberculosis, which is very, very important. And then you have certain rare causes of lower respiratory tract infection. For example, you have some fungal pneumonia. Fungal pneumonia is rare, but it does happen. And then you have certain parasitic lung disease. Okay, I'll tell you one important finding. I got it last week. I'll tell you what happened. And then there is lung abscess and pleural effusion and pleuritis. So এতগুলো জিনিস হচ্ছে is under the umbrella of lower respiratory tract infection. It is not only pneumonia. আমরা জানি যে LRTI মানে হচ্ছে pneumonia, but no, pneumonia ছাড়াও দেখো এতগুলো জিনিস আছে which is included under the lower respiratory tract infection. So we will just move on to the individual topics. Pharyngitis is the inflammation of the pharynx. As the name suggests, it is done by the Streptococcus pyogenes. Very important bacteria for the upper respiratory tract, that is Streptococcus pyogenes, that causes inflammation of the pharynx. Patient কি নিয়ে আসবে? Patient তোমার কাছে আসবে গলা ব্যথা, প্রচন্ড গলা ব্যথা, এক সপ্তাহ ধরে, 2 সপ্তাহ ধরে। You examine the throat, you see the pharynx is totally swollen. আর কি কি থাকতে পারে? You have heard the name of diphtheria, Corynebacterium diphtheria. What does it do? Corynebacterium diphtheria কি করে বলো? Last bench. Corynebacterium diphtheria কি করে? Diphtheria করে। ডিপথেরিয়াটা কি হয়? How does the patient present? জল অফ হয়ে যাবে ডিপথেরিয়াতে, এ তো মুশকিল। কি হবে ডিপথেরিয়াতে? কাফ হবে, টনসিলাইটিস হবে। টনসিলাইটিস ঠিক হবে না। You can say that the fascial pillar will be involved, but not exactly tonsillitis. আর তুমি জলকটা কোথায় পড়েছো? There is a pseudomembrane. Pseudomembrane কোথায় থাকে? A whitish patch, a whitish pseudomembrane will be present over the tonsils. ও tonsillitis বলেছে, she is close to it, but তুমি তো অন্য দিকেই চলে গেছো, জলক হয়ে গেছে। জলকটা কোথায় হয়? Next question. You are inviting trouble. Where you find জলক বলো? TMG জয়েন্টটা কোথায় থাকে বলো দেখি? টেম্পোরোম্যান্ডিবুলার জয়েন্ট থাকে তো? তো ইনফ্লামেশন অফ দ্য টেম্পোরোম্যান্ডিবুলার জয়েন্ট ক্যান গিভ ইউ আ জ লক। অর তুমি ক্লস্ট্রিডিয়াম টিটানিতেও হতে পারে। তুমি কর্নিব্যাকটেরিয়ামের সাথে ক্লস্ট্রিডিয়ামটা গুলালে না? That is exactly what you did. Clostridium tetani causes tetanus. Corynebacterium diphtheria causes diphtheria. Diphtheria is nothing to do with jaw lock. It will form a whitish pseudomembrane. এখানে আছে ছবি। See here. দেখা যাচ্ছে? This is a paratonsillar area, a fossal pillars. সেখানে if you notice there are whitish membranes. These are not true membrane. This is a pseudomembrane. So the whitish pseudomembrane is being formed over the tonsillar area. Never ever commit a mistake to pull that membrane. They একটু নিয়ে একটু biopsy পাঠালাম, একটু নিয়ে কালচার পাঠালাম, ওইটা করতে যেও না, তাহলে patient will be dead. It will bleed heavily. Okay, so this pseudomembrane is formed by the Corynebacterium diphtheria. Okay, so see pharyngeal infection এর কতগুলো spectrum. If you can see enlargement of the the lymph nodes. And then you see inflammatory exudate or suppurative infection caused by Streptococcus pyogenes. And then you have Corynebacterium diphtheria, সেটা কিনা pseudomembrane formation. And of course there is HSV, herpes simplex, which causes some vesicles over the tonsillar area. So these are the things that you will find in the pharyngitis. Laryngitis কি আছে? Laryngitis again is caused by many viruses. All the influenza viruses, parainfluenza virus, adenovirus, these are all the causative etiology for the laryngitis. Laryngitis এর patient কি নিয়ে present করবে? They will be having some problem with voice pattern. So they will be having some hoarseness. They can also have some pain in the throat. Okay, so there is inflamed larynx. If you can see, this larynx is inflamed, it is red and it is swollen. So that's how it presents. Mostly it is a viral disease, rhinovirus, adenovirus, influenza viruses, they cause the laryngitis. Eguloর ক্ষেত্রে there are no specific antivirals, you only have to tell the patient that you rest your voice, you humidify the upper respiratory tract. Steam inhalation we suggest, okay, and then you have to take the voice rest. An adequate amount of fluid has to be taken. Or jar asli you can have to take paracetamol. That's all. Next is very important, which is acute laryngotracheobronchitis. So it involves larynx, trachea and bronchus. So what happens is the thing starts from the larynx. The child will be having a hoarseness of voice. Then it will be slowly traveling down the trachea and it will be involving the bronchus. So the child will be having kind of cough, which very loud noise. Okay. So that is called croup. Again, it is done by the Haemophilus and some mycoplasma. Acha, mycoplasma pneumonia. Have you heard the term walking pneumonia? What is walking pneumonia? Bolo dekhi. Bolo. Why have you sit in the last bench? Come in the front bench. I was searching for you. Yes. What is walking pneumonia? Yes, correct. So she is correct. Walking pneumonia mane hocche a kind of, see, pneumonia mane, sit down. A pneumonia, we know that a patient is suffering from pneumonia, he or she will be having respiratory distress, saturation কমে যাবে, patientটাকে ventilate করে দিতে হবে, IV antibiotic দিতে হবে, all these things, the patient has to be admitted. But there is one organism, mycoplasma, which causes pneumonia. It is called walking pneumonia because the patient will be having pneumonia and he'll be walking all over the hospital. He can walk home, he can go to the OPD and do whatever he wants, but the patient will be having pneumonia. So that is why it is called walking pneumonia. It is treatable, of course, with antibiotics, and the patient can be admitted if he is having a respiratory depression, but mostly it is treated by OPD visit only. Okay, so that is why it is called walking pneumonia. Acha, এই ক্ষেত্রে যদি the bronchus is involved, then we start antibiotics mostly to the mycoplasma and influenza. Now epiglottitis, as I said, it is a medical emergency because this is one thing which, if it is inflamed, you will be having severe respiratory distress, you will be having severe airway block. Okay, so you are breathing, but the air is not reaching the lungs because there is midway the epiglottis comes and the epiglottis has got inflamed and it has completely blocked out the pharynx. Okay, so that is important. You have to diagnose it very fast, as because it is a bacterial infection, Haemophilus. and then you have to treat the patient with antibiotics in case the patient is having severe distress or absolutely blocked. Then you have to do a tracheostomy or something like that. Alternate method, we have to make the patient breathe, but then this is treatable and this is curable. Okay, but patient jodi epiglottitis niye ashe, it is advised that you give antibiotics at the first, otherwise this will go on increasing and you may land up in respiratory distress. So what are the antibiotics we give? We give a combination of cephalosporin along with vancomycin. So we give ceftriaxone or cefixime along with vancomycin. So that is the drug of choice. Mostly this occurs in the children age group. Okay, the patient comes with throat pain, the patient may come with respiratory distress, the patient will come with fever and foreign body irritation in the throat, and sometimes painful speech also. Hoarseness of voice can also be a presenting symptom. Another thing is called Ludwig's angina. এখানে কি হবে না, this is directly not involving the pharynx, this is involving the mandibular space. Okay, you see this is the mandibular space both on the left side and the right side. So whenever the mandibular or the submandibular space is involved and it is inflamed, what happens is the patient's face becomes swollen. The base of the face becomes swollen. Okay, now this is again caused by certain bacteria, which are mostly colonizing our gums and teeth. We have viridans streptococci, we have peptostreptococcus. All these things are colonizers of our mouth. So those things, if the patient is having any kind of gum infection or the patient is having any kind of immunocompromised state, those things can creep up and infect the submandibular or the mandibular space. সেখান থেকে you will have a facial swelling. You can have elevation of the floor of the mouth and displacement of tongue. সেক্ষেত্রেও you have to start antibiotics. Mostly the gram positive antibiotics will be started because the presenting most organisms belongs to the group of streptococcus, peptostreptococcus and viridans streptococci and those things. Then you have atrophic rhinitis. Okay, the people who uses mostly this xylometazoline, oxymetazoline, those kind of drugs jara prolonged use kore, it is, if you see any kind of prescription who has done from a from a recognized place, you will see that the doctor will prescribe Nazivian drop. Nazivian drop ta dekhbe 7 দিনের বেশি কেউ দেয় না. Have you seen? নাক বন্ধ হতেই পারে, but you cannot use it more than 7 days, because if you use it more than 7 days, it can change the epithelium of the nose. So you can have these kind of things, rhinitis. Okay, but these cases are mostly infected cases. That's why we are discussing. Atrophic rhinitis is infected case. It is also called ozina because it is caused by certain bacteria known as Klebsiella pneumoniae subspecies ozini. Okay, এটা একটা kind of biochemically inactive Klebsiella which doesn't cause which can cause a LRTI, but it is mostly focusing, it mostly causes upper respiratory tract infection. সেটাকে বলে ozini. তো এখানে patient will be having nasal secretion, foul smelling nasal secretion, and the patient may have, will have atrophy of the nasal mucus, and we will have to treat the patient for 1 to 2 months giving certain fluoroquinolones. Ciprofloxacin is the drug of choice. We have rhinoscleroma, which is a dysmorphic a problem with the nose. You can find this disease in India, you can find in some parts of the America, I think Central America, and then you have also in the Europe. So these places, again, Klebsiella pneumoniae is the causative organism, but in this case the subspecies is rhinoscleromatis. Okay, তাহলে Klebsiella pneumonia কিন্তু LRTI ও করে, URTI ও করে. Subspecies ozini causes atrophic rhinitis, subspecies rhinoscleromatis causes rhinoscleroma. এখানেও কিন্তু we have to treat the patient with ciprofloxacin for 2 to 3 months. Then we have sinusitis, everybody's favorite thing. মাথা ধরেছে মানে সাইনাসের প্রবলেম, তাই তো? হ্যাঁ, কি করবে সাইনোসাইটিসে? The thing is that you have to drain the sinus. So there will be collection in your sinus spaces all over the maxilla and frontal bone. So there will be collection of mucus and epithelial debris in the sinus. So that will make your face heavy. That will give rise to a frontal headache. That will give rise to a nose block. That will give rise to anosmia. That can give rise to fever. That can give rise to a lower respiratory tract also sometimes if it is not treated or if it is prolonged. And yes, that can also give rise to epistaxis. Epistaxis means ki? Bleeding from the nose. So whenever your sinuses are not getting cleared, your epithelial mucosa will be damaged. And your epithelial mucosa is damaged, then you can have a epistaxis. The person who put their hand in the nose all the time, those patients. Okay, so mostly these are viral. You don't have to give antibiotic or antiviral for that. Mostly you have to give steam inhalation. So whenever you are giving steam inhalation with some that Carval Plus, you have small green capsules that works like wonder. I give to my patients Carval Plus. Carval Plus diye boiling water theke if you inhale steam, that opens up the opening, the sinus openings. So that may help to drain the collection. So that is what. Jodi chronic hoy sinusitis, then it is not treated with medicines, then you have to do the facial endoscopic sinus surgery. FES bole একটা surgery আছে সেটা করতে হয়. Mostly to the patient who have epistaxis all over the ear. If you do a CT scan of PNS, you will see that thickened sinus epithelium has occurred. The epithelium টাই যখন thickened হয়ে গেছে তখন sinus clearance টা হবে কি করে? Then you have to do a facial endoscopic sinus surgery. Okay, lab diagnosis কি করে করবে এত তো জিনিস দেখলে? So return back to the COVID era. COVID era তে আমরা lab diagnosis কি করে করেছি? Swab. What kind of swab? Nasopharyngeal swab and oropharyngeal swab. 2 swabs has to be taken. And the important thing is the swab material. If you remember the COVID swabs, those were not cotton material. Cotton এর কিন্তু ছিল না swab গুলো. Oropharyngeal টা হয়তো cotton এর ছিল, but nasopharyngeal was never a cotton swab. Because whenever you use a cotton swab, cotton is a absorbent. It is not a adsorbent. Adsorb মানে কি? সারফেসে রেখে দেবে। আর কটন হচ্ছে অ্যাবজর্ব করে নেয় ভিতরে। তো when you are using an absorbent swab, so what is the point? It is getting inside the swab. I need to do a PCR from the swab. So I need to get the material on the swab, not in the swab. So that is why we use rayon or dacron swabs. Okay, those are called flocked swabs. Flocked মানে হচ্ছে যে বাড়িতে ঝুল ঝাড়ু হয় না, দেওয়ালের ঝুল যেগুলো দিয়ে ঝাড়ে, দেখবে একটা এরকম কাঠির উপরে সব লাগানো রয়েছে, that is flocked. So that is exactly the swabs that we use for the nasopharyngeal samples. Okay, next you go for a direct smear, but upper respiratory tract যেহেতু mostly viral, সুতরাং direct smear you won't get anything. So what you have to do is you have to do a molecular diagnosis, or if it is a Haemophilus or Streptococcus Pathogens or pneumonia, then you have to put in the blood agar and chocolate agar. But mostly we use this method now, molecular method. We have multiplex PCRs, as I was explaining. Ki ekta panel er moddhe you have COVID, you have adenovirus, you have influenza A, you have H1N1, you have so many things are there in one panel. So we do a multiplex PCR and we get the diagnosis ki which bacteria or which virus is causing the disease. Because you see, culture takes a lot of time, and these are all fastidious organism. Haemophilus is a fastidious organism. Half of the time, if you don't create the nice environment for Haemophilus, it won't grow. So that is why we depend on molecular. But parallelly, we also do a parallel culture and antigen detection. Kichu bacteria khetre antigen detection ache jerokom Streptococcus Pathogens jodi you have to detect from throat swab, you have antigen immunochromatography cards. সেখানে দিলে you will get a brand. এরকম একটা কন্ট্রোল ব্যান্ডের সাথে there is a test band which signifies that there is a positive presence of Streptococcus Pathogens. So these are there. Now we have oral cavity infections. I'll just skip it fast. We have stomatitis, that is inflammation of the mucous membrane of the oral cavity. You have oral thrush, candidiasis. It is very, very prevalent in HIV patients. So mostly HIV patients will be having this oral thrush. তাই জন্য ওদেরকে দেখবে chlorhexidine mouthwash করতে বলা হয়. Then you have any kind of chemotherapy patients who are on certain chemotherapeutic agents that takes down your WBC counts. সেখানেও কিন্তু we suggest the patient to use chlorhexidine because all these things will be coming যে আমার মুখের মধ্যে যে colonizationটা হচ্ছে সেই colonizationটা will take a rapid turn and that will cause oral thrush. So you don't have to have a oral thrush in patients. That's why we have to prevent it. And then you have dental and periodontal infection. Dental infection আমি বেশি যাব না because it is mostly out of our scope. Salivary gland infection আমি already আগের দিন বলেছি, mumps, it causes parotitis, and acute suppurative parotitis যেখানে there is a bacterial infection, it can also be caused by Staph aureus. Suppurative infection যেখানেই হোক না কেন Staph aureus can be the causative organism, এটা কিন্তু মাথায় রাখবে. Suppurative infection দেখে E. coli লিখে দিয়ে চলে গেল, no, Staph aureus is the first thing that you should rule out. It should be the first thing that should be in your mind. Vincent's angina is very important. মাঝে মাঝেই আসে question. It is also called trench mouth. That person will smell horrible. That is why it is called trench. কি হবে না, ফার্স্টে you see this healthy gum চকচক করছে and you see this Vincent's angina, all kind of flaky, membranous, whitish scabs which are there, gums near the teeth. So this is mostly caused by bacteria. কে করবে, কোন ব্যাকটেরিয়া করে Vincent's angina? ব্যাকটেরিয়াটার নামের মধ্যে ভিনসেন্ট আছে, বলো দেখি. Which organism causes Vincent's angina? Borrelia, correct. So Borrelia vincenti causes Vincent's angina. See, Borrelia vincenti, the primary organism. Next, you have certain anaerobic organism in the gum also. Tara kara, tara hocche, you have Peptococcus, you have Prevotella. So all these things are anaerobic organisms which live in the gums, inside the gums. ঠিক আছে? So those things, Fusobacterium, so those things are also a causative organism for Vincent's angina. The diagnosis has to be clinical. You can give gum swabs for culture, and then you have to treat the patient with primary debridement, because if it is this state, then the antibiotics won't work. You have to debride this area and then you have to give the antibiotics. So that is how it is done. Coming to the lower respiratory tract. Lower respiratory tract আমি already বললাম কি কি রয়েছে. First হচ্ছে bronchitis, that is a plain inflammation of the bronchus. কারা কারা করবে? Now you have mostly viral, respiratory syncytial virus, you have adenovirus, you have influenza virus, you have coronavirus. So all these viral causes are there, which are the most common. কিছু কিছু ক্ষেত্রে you have mycoplasma also doing it, bacterial causes মধ্যে. Acute bronchitis যেহেতু mostly viral, we give the patient paracetamol and supportive treatment. But যদি সেটা chronic হয়, যদি there is a bacterial etiology, then you have to treat with antibiotics. But remember, fluoroquinolones are now reserved drugs. You cannot give a levofloxacin to the patient rampantly because it is reserved because of use in tuberculosis. Okay, আগে অনেক দেওয়া হতো fluoroquinolone, but এখন usage-টা অনেকটা কমেছে. You have bronchiolitis, that is inflammation of the bronchioles. Mostly it occurs in young children and infants. এটাও most common cause হচ্ছে virus, respiratory syncytial virus. So we have to wait and watch. You have to give supportive therapy with adequate hydration, you can give nebulization also sometimes. Chronic bronchitis কাকে বলছে না, we have when the bronchitis is persistent for more than 3 months per year. এক বছরে যদি 3 বারের বেশি bronchitis হচ্ছে, then we can categorize into chronic bronchitis. And you see chronic bronchitis will be presenting again with cough, but this time with expectoration. So there is a possibility that the bronchial mucosa is getting damaged and that is getting infected multiple times in a year, probably with certain gram positive organisms. And you see all the patients who have COPD. COPD is a very important disease because COPD patients ra kintu they have a very poor prognosis. If the patient is starting having a chronic bronchitis, the recovery is very poor. COPD patients, if they are on a ventilator, if they are on a supportive mechanical ventilator, the recovery is very poor. And what is the primary cause for COPD? Previously we used to tell smoking causes cancer. Now we are telling in fact, smoking causes COPD mostly. যারা যারা স্মোক করে সবার কি লাং কার্সিনোমা হয় না, বাট ম্যাক্সিমাম কেসে ends up in COPD. ক্যান্সার ভুলে যাও, COPD will give rise to trouble every time of the year. When it is a winter, when it is a rainy season, when the starting of the summer, you will see the patients are coughing and they are having productive cough. সারা জায়গায় কফ থুতু ছড়াচ্ছে. That is COPD, mind you. And those patients will come to you in the OPD. সিজন চেঞ্জে ঠান্ডা লেগে যাচ্ছে, সিজন চেঞ্জে কাশি হচ্ছে, স্মোকিং চলছে, তো কাশি হবে না কেন, তাই না? So COPD is very, very dangerous. Please keep in mind and tell your patients not to smoke. So we have whooping cough, bordetella pertussis. Already I think it is done in the previous classes. It is a gram-negative organism which causes certain coughing pattern which is called whoop. এরকম একটা সাউন্ড আসে কাশির সময়, তাই জন্য বলে হুপিং কাফ। নিউমোনিয়ার মধ্যে চলে আসি। নিউমোনিয়ার মধ্যে ফার্স্ট থিং ইজ কমিউনিটি অ্যাকোয়ার্ড নিউমোনিয়া। দ্য পেশেন্টস হু উইল কাম টু ইউ উইথ আ লোয়ার রেসপিরেটরি ট্র্যাক্ট উইল বি মোস্টলি ক্যাপ। ক্যাপ মিন্স কমিউনিটি অ্যাকোয়ার্ড নিউমোনিয়া। ওল্ড পেশেন্টস, দ্য থিং ইজ কমিউনিটি থেকে কি করে আসবে ইনফেকশনটা? আধা ইনফেকশন নিজের শরীরের মধ্যে থেকেই আসে। ওল্ড পেশেন্ট যাদের কিনা কাফ রিফ্লেক্সটা খারাপ, দে ইউজুয়ালি ডু মাইক্রো অ্যাসপিরেশন। আমাদের ওরাল যে সিক্রিশনস গুলো আছে ফুল অফ অর্গানিজমস, those organisms trickle down the trachea, and because the mucociliary clearance is very, very poor, those organisms will cause a pneumonia. কারা কারা করছে? হিমোফিলাস করছে, স্ট্রেপ্টোকক্কাস করছে, মাইকোপ্লাজমা করছে। Okay, so all these things causes community acquired pneumonia and also respiratory syncytial viruses. Nowadays H1N1 is on rise. Influenza A, H1N1 is on rise, so keep it in mind. So these are the the predisposing factors: alcoholism, and second is COPD. See, everywhere you will find COPD. You will go to medicine, you will find the respiratory cases, you will find COPD. Maximum cases you will find in OPD is COPD. All smoking. And then you have yes, this I've already discussed. You see the spectrum of organism between a CAP and a HAP. HAP means hospital acquired pneumonia. এই যে organism গুলো Pseudomonas, Acinetobacter, E. coli, the escape pathogen. You remember escape pathogen? I have taught in the previous class, escape pathogen. So escape pathogen এর মধ্যে কিন্তু সব পড়ে যাচ্ছে। See, E. coli আছে, Klebsiella আছে, Acinetobacter আছে, MRSA রয়েছে। So all these things, multi-drug resistant organism will cause hospital acquired pneumonia. But if you see community acquired pneumonia, completely alada spectrum. Streptococcus pneumonia, Mycoplasma pneumonia, Haemophilus influenzae, Chlamydophila. So all these things are community acquired. এগুলো কিন্তু হসপিটালে খুব একটা হয় না। And again you have virus, COVID-19, influenza, as I told, H1N1. So all these are community acquired. I've already told what is a lobar pneumonia. It is affecting the lobes of the lung, and lobar pneumonia kintu stage hocche, it will be having a consolidation. If you do a X-ray, if you do a CT scan of the chest, HRCT of the chest, you will find that lobar pneumonia will be mostly presenting with the consolidation. But interstitial pneumonia te kintu সেরকম হয় না, এবং interstitial pneumonia kintu doesn't present like a normal pneumonia. It can present with non-productive cough. Lobar pneumonia te generally the patient presents with productive cough. Productive mane you have cough along with the expectoration along with the cough. Interstitial pneumonia is mostly caused by atypical organisms like Mycoplasma, like Chlamydophila. Lobar pneumonia is mostly caused by typical organisms like Streptococcus. Okay, pneumonia patients will come to you with a history of fever, with a history of shortness of breath, with a history of cough, with a history of hemoptysis, with a history of production of the cough during production of the expectorant during the cough. So all these things are the presenting complaint of the pneumonia. So in case you have a community acquired pneumonia, you can give the patient with oral antibiotics. You can give amoxicillin and clavulanic acid. In severe cases, you have to give a third generation cephalosporin IV. Okay, So we can give a ceftriaxone 1 gram twice daily IV. Patient to ceftriaxone বাড়িতে নিতে পারবে না, ceftriaxone কে hospitalization নিতে হবে. But if you have to give IV therapy at home, that is also possible. OPAT বলে জিনিসটাকে, outpatient antimicrobial therapy. সেখানে কোনো রকম হসপিটালের নার্সিং স্টাফ কিংবা যারা ডক্টর আছে তারা গিয়ে they give the antibiotic at home if the patient is not willing to come to the OPD. But in case of hospital acquired pneumonia, definitely you have to take the patient in, you have to admit and start the IV antibiotics early, because the patient, the old debilitated patient, they lands up into respiratory problems very fast. And if the patient is having a COPD, then it's a huge problem, COPD. Okay, rare etiological agents of pneumonia, as I was telling, Aspergillus and Pneumocystis, they cause pneumonia in some patient. Pneumocystis is not very rare. We do see Pneumocystis sometimes, but bakigulo it is a bit rare. Histoplasma and blastomyces, those systemic fungal infections, secondary systemic fungal infection থেকে respiratory epithelium যেতে পারে. But mostly you see fungal infections, respiratory tract are mostly concerned with the immunocompromised patients. Immunocompetent খুব একটা হয় না. অনেক আরো কজ আছে, বার্কোলডেরিয়া আছে, মেলিয়াডোসিস আছে, নোকার্ডিয়া আছে, সিটাকোসিস আছে. So these are atypical, very rare cause of pneumonia. Tuberculosis, as you know, that it is the mostly primary, the site is lungs. The patient will come to you with a chronic fatigue, weight loss, hemoptysis, cough with mostly non-productive cough, that is dry cough, and you have to diagnose the patient radiologically and with microbiological tests. HRCD করতে পারো, X-ray করতে পারো, but one thing that you have to do is a sputum ZN stain or a sputum TB PCR or a sputum MTB culture. So all these things are the diagnostic test of the TB. One thing is pulmonary tuberculosis যেমন আছে, extra pulmonary tuberculosis also exists, and there is something called latent TB. TB তো হয়ে গেছে তোমাদের, না হয়ে গেছে? তো হয়ে গেছে না হয়নি সেটাই বলতে পারছে না. TB is done or not? হ্যাঁ হয়ে গেছে? এই তুমি হ্যাঁ করছো কেন, না করছো কেন? মাইক্রোব্যাকটেরিয়াম হয়ে গেছে? হয়নি? দেন সো হয়নি, তারপর না করছো হ্যাঁ করছে. ওকে, সো হাউ ইজ টিবি ট্রান্সমিটেড? কি দিয়ে ছড়াচ্ছে টিবিটা? হ্যাঁ, হাওয়া দিয়ে? ওটা তুমি কি পরীক্ষা খাতায় হাওয়া দিয়ে লিখে আসবে? এরোজল. So TB is a airborne infection. So it is transmitted by aerosols, respiratory aerosols. Okay. Then you have lung abscess. Have you imagined that এতক্ষণ ধরে যেগুলো পড়লাম, have you seen anaerobic bacteria? No. Lung এর মধ্যে কিন্তু anaerobic infection হয় না, তাই তো? It is full of oxygen. Lungs is full of oxygen. How will the anaerobe survive? It will die. Anaerobic infection কোথায় হয়? গামসে. গামের ইনফেকশন গুলো অ্যানারোবিক হয়, বাট লাং এর কিন্তু অ্যানারোবিক ইনফেকশন হয় না, এক্সেপ্ট দিস. This is a lung abscess. Lung abscess means there is an abscess which is completely cut off from the gaseous exchange part, which is the primary function of the lung. সেখান থেকে কাট অফ হয়ে গিয়ে একটা অ্যাবসেস তৈরি হয়েছে. This can be a anaerobic abscess. So in those cases you have to treat with anaerobic drugs. Okay, so the patient will be again coming with fever, productive cough and chest pain and respiratory distress. Pleural effusion is very common, but pleural effusion er bacterial cause is not very common. Pleural effusion er mostly the causes are non-infective, but yes, in many cases like tuberculosis you can have a TB, tubercular pleural effusion. এছাড়াও আরো অনেক কজ আছে, ব্যাকটেরিয়াল নিউমোনিয়া থেকেও সেকেন্ডারি প্লুরাল এফিউশন হয়, বাট মোস্টলি প্লুরাল এফিউশন ইজ নন ইনফেক্টিভ. ওকে, yes. Now LRTI, how will you diagnose? There are many samples of the lower respiratory tract, not only sputum. We know only one sample, that is sputum. Sputum ছাড়াও যে পেশেন্ট গুলো অ্যাডমিটেড আছে, যে পেশেন্ট গুলো ভেন্টিলেটেড আছে, কিছু পেশেন্ট আছে যারা কিনা দে ডোন্ট হ্যাভ কাফ রিফ্লেক্স, কাশতেই পারবে না. ইউ ডু আ ব্রঙ্কোস্কোপ ইন দোজ পেশেন্টস. But if you have suspicion of any kind of intra lung any kind of change, then you can do a bronchoscopy. So bronchoscopy kore we will find a bronchoalveolar lavage. So that bronchoalveolar lavage is a very important sample because it is directly coming from the bronchus to you. Sputum is a very poor sample because the patient will be coughing of sputum. 70% of the patient cannot cough off properly. Ki korbe mukhe thututa diye debe. And you will see that the slide is full of epithelial cell from the mouth. So it is a very poor specimen. It will be loaded with gram-positive organism, gram-negative organism, but none of the organisms are from the lungs. All those are from the mouth because it is a saliva, it is not sputum. Sputami jodi thakbe, then you will have the pus cell count of more than 25 and the epithelial cell count will be very low. It will be less than 10 or 10 to 25. So the sputum is a very poor quality specimen in some cases. The good specimen from the lower respiratory tract are ET suction, endotracheal tube suction. You have protective, bronchial brushing. You have bronchoalveolar lavage fluid. So all these are good samples or very important samples from the lower respiratory tract. So what you will do is, you will do a gram stain, you will do a Zn stain. Gram stain korle dekhle prochur gram negative bacilli. But you cannot tell from a sputum sample that this will grow to be a Klebsiella or not, because it is colonized with so many organisms in the mouth. But if you find any kind of gram-negative bacilli in bronchoalveolar lavage fluid or endotracheal tube suction, that can be a pathogen. So in those cases, you have to inform the critical care. I can see many organisms in the slide. And then you have Zn stain. If you find tuberculosis, the whole story changes. So we do a culture in the blood agar, we do a culture in the chocolate agar, and then we try to find out the organism. That's how we do it. In case you are having a suspicion that the patient might have a secondary infection, the lung is a secondary site, then you can also do a blood culture parallelly. In case you have suspicion of the tuberculosis, you will put a LJ media. But LJ media is replaced by, Middlebrook. It's not replaced, we do LJ cultures, but Middlebrook liquid based cultures are mostly preferred. So Middlebrook media also we use, LJ cultures also we use. LJ culture, you can see the colonies of the tuberculosis. So that is very important. Yes, we do a lab diagnosis with these tests. Ato difficult er moddhe jawar darkar nei, just remember culture, PCR. Antibody doesn't play such role because you see antibody is developed when the infection has been there for at least 7 days. Right? So you cannot rely on antibodies first. You have to rely on the antigen. You have to rely on the DNA. You have to rely on the RNA. You have to rely on the cultures. So culture is the main part, followed by PCR. PCR is very important. It will give you the result in 4 to 5 hours. If you are having a biofire, it will give result in 1 to 2 hours. Okay, but it is costly. PCR samosto jagay nei, PCR samosto jagay thakaro possible noy, and everybody cannot afford a PCR, a multiplex PCR, because that is very costly. Biofire costs you around, I think, some more than 16,000. Okay, so that is affordable challenge in some patient. But we have other tests also. We have certain direct fluorescent testing. কিছু কিছু ক্ষেত্রে করা হয় বর্ডারটেলা মোস্টলি অর্গানিজম আছে বর্ডারটেলা পার্টুসি সেখানে ইউ হ্যাভ antibody testing, antigen testing with a fluorescent probe. But you have seen COVID, right? COVID day we have done PCRs and PCRs every day. 3,000, 4,000 PCR samples were being run in COVID. So viruses cannot be diagnosed without a PCR. You don't have a viral culture lab here, and we cannot rely on the viral culture also. So the diagnostic method for viruses are PCR. Okay. So these are the questions. These are very undecipherable here. If you have the PPT, you can take down the question. এখান থেকে ছবি তুলে লাভ নেই, কিচ্ছু বুঝতে পারবে না. Okay. So probable questions I have written you down. You can take the questions and then you can study. Okay, anything that you want to ask?